So I think we all are recognizing that we need uh, improved methods of determining when to stop maintenance, when to start maintenance, how many cycles of upfront therapy. And right now, we've been using things like FDG scans, we've been using flow, and I think that using next-gen seq to look at cell-free DNA, I think offers the opportunity to get a single sample that can, we believe, reflect in large measure the overall burden of tumor there. And so I've named this circulating tumor DNA. In this study we did that we published in Lancet Oncology last year, I say pulling a rabbit out of a hat because this really comes from the idea of a magician having a hat, nothing's there, and then suddenly you're able to find something. So we used a strategy here, and this is actually a collaboration that we did with Adaptive, and this is using next-gen seq, and these were serum samples, so they were cell-free. You use consensus primers and to actually PCR up the VDJ area. Then you do next-gen seq to look for unique strands. And then if you in fact find a unique clone that exceeds 6% of the, and this is the threshold they used, was higher than 6% of all the others, that was the clone we would actually follow. Now we did this in two different ways. This is from, kind of hard to see this, this is from a study. This is a prospective study of EPOCH-R in large cell. We started out with 198 cases. Now, let me just say that since around 1992, I instituted getting serum samples with every single cycle and every single restaging CT scan on every upfront large cell case we had. So we had sitting in the freezer thousands and thousands of samples that we could actually do this study in. And the reason we were actually doing that was because we knew that there was nothing we could look at for this back in 1992, but I was looking ahead and hoping that we would be able to use these samples for a study like this. Now the samples you could identify the clone, preferably if you had a pre-treatment biopsy sample, and in about 90% of pre-treatment biopsy samples, we were able to find the clone. For those patients that had no more of the upfront biopsy samples, we then looked to see in the pre-treatment serum samples, could we identify a dominant clone there? And we were able to find a dominant clone in 1/3 of the pre-treatment serum samples as the primary source. And then make a long story short, we then followed and looked at what the association of this clone was with outcome, keeping in mind that all these patients had been followed for many, many years, and they all had samples obtained at the same time they had CT scans. So although this was not a prospective study, all the samples were present and all of the analyses were performed in a totally blinded manner. So this actually gives you the kinetics of what we actually found. So this is actually looking at the number of lymphoma molecules per 10 to the 6 diploid genomes. And this is looking at what the pre-treatment looked like. And you can see there was a large range here. And what we found was that the actual quantitative amount of circulating tumor DNA was statistically correlated with the tumor volume. So it actually turned out to be a correlation that was very, very nice. Now, if you look at what happened after 2 cycles, 51% now of the samples were still ctDNA positive, meaning that within 2 cycles, we were able to clear it with chemotherapy. By 3 cycles, we came down to 22%, and you can now see that by 4, 20%, 5, 11, 6, 11, and at the end of therapy, 7.3. I think what this tells you is that if in fact you went down to 0 at this point, many of those people may have been cured even if you had stopped therapy at that point. So this is actually kind of showing you among those cases that weren't cured, kind of the actual way in the actual quantitative increases of these clones over time. And these are the months before clinical relapse as documented on a conventional CT scan. So this is actually looking at those cases that actually progressed within 6 months of therapy. And what you see here in the red dots are the cases that are ctDNA positive. The open circles would be ctDNA negative, and the square circles is when the CT scan became positive for tumor. Again, this was all done blindedly. And what you will find is that most cases that actually failed continue to have positive ctDNA at cycle 2. And that many of these cases remain positive throughout their entire course. If you actually look at this on a Kaplan-Meier curve, and what we call this is we call this interim ctDNA as a function of time to progression. So this is looking at ctDNAs that were positive at the start of cycle 3. And you can see that if you became ctDNA negative by cycle 3, your EFS was 80%, and if you were positive at cycle 3, your EFS was about 42%. So again, this was very similar to what people have done with FDG, where they've looked at the ability of an early scan to predict whether or not someone's going to do well. Now, I think what is more useful here, and for me, more impressive, is looking at what the ctDNA did in patients who either had no relapse or relapse beyond 6 months. You can see that most cases here, out of 88 cases, they turned negative, they stayed negative. You can see here that there were 2 cases that actually turned positive and then later turned negative. And I'm not going to go into the technical reasons, but we technically went back and retested these blindedly, and the retest came back negative. So we believe that these were false positives and did not represent true disease. In this case, we were still unable to show that, but what we have now found is that about three months ago, this patient actually developed actual tumor. Now, among the cases that turned positive, you can see here in almost all cases, the ctDNA turned positive before the CT scan turned positive. So it actually gave us about 3 to 4 months lead time on prior to the CT scan becoming positive. And if we look at what the Kaplan-Meier curves look like, those patients that remained throughout this ctDNA negative are shown here, and those that turned ctDNA positive are shown here. And so this was a highly accurate with a specificity and sensitivity well over 90%. And this is actually giving you the lead time for those cases that relapse beyond 6 months. We were able to predict relapse with a median of 3.5 months prior to the scans coming positive. Now, what I want to talk about now in the next 3 slides, which are my last slides, is how can we begin to think about using a test like that? And this is giving a number of the different scenarios that we actually saw. This is looking at ctDNA kinetics in a curable cancer, okay? And so this would be, in the case of the study we did here, this would be diffuse large cell. And what we saw is we saw these 4 different patterns, and they are the same patterns that I am showing here. There were those cases that had no relapse, and what they did is most of these cases came down and turned negative. This is the detection of ctDNA, and this is the detection limit of imaging. Virtually all of these cases turned negative by the beginning of cycle 3 and remained negative. And the median follow-up of this trial, I think, is something like 9 years. We also had patients who had early relapse. Those cases that came down went negative, but then came up relatively quickly. And with this group, we were still able to predict using ctDNA lead time. There were those cases that were primary refractory where they never went down, and in those cases, the ctDNA came up quickly. And then there were a few cases where the relapse was very, very late. We had 2 cases, both of which relapsed beyond like 10 years, and we were able to pick those clones up. And in one case, the ctDNA was positive, so we went back and scanned them because we stopped scanning, and we were able to find a very small lymph node. We biopsied it, and bing, we found tumor. So I think this is also something that can be used for clinical trials, and this is giving how you might use something like this for maintenance. And here again, you can have. I'm showing here. This is where you give induction therapy for those that get maintenance therapy. It would be here. And then there would be a group that you could be treating not with maintenance, but in the relapse setting. And you can do delayed maintenance where you can give induction therapy and you can be going down to negative. But what you can do is when it starts coming up, you can then at that point consider coming in with your therapy and actually looking at whether or not your therapy, when the tumor load is very, very low, is able to actually drop it down again. So this is using ctDNA as a molecular marker to decide when to restart therapy before the tumor actually becomes clinically obvious. There's also the cases, and we've heard about this, where you get people down to very low levels and they stay there. So the question is that after a year, do you continue giving drug or do you actually stop? And then finally, there are those patients that are getting therapy but actually grow on it, and this is shown here. And the question comes up then: do you change therapy or do you simply keep on treating them, even though you know that on therapy the clone is actually rising? And this is where actually doing mutational analysis of the tumor may be useful. You start out with a tumor that is obviously mostly of one clone, but you're going to have scattered clones. And one thing that can happen with tumors is they can acquire MYC. And so if you in fact were able to identify using next-gen-seq that a MYC is coming up, you may want to use a different drug, or perhaps later on something related to P53. But when you start to think about using this kind of technology, using the actual clone itself to measure tumor load below the level that we can see clinically, and you could pair it with this, where you can begin to think about selecting therapies that are relevant and treating before the disease actually becomes clinically there. Thank you very much.
Dr. Wilson, thank you very much for this nice presentation. Do you have some data, same data, but in bags after mobilization and apheresis before autologous stem cell transplantation?
No. All of this data was done in the upfront large cell.
Thank you.
Really nice presentation. I'm fascinated for the information. My question is about the if you have any correlation to level of ctDNA before to start the treatment with the chemoimmunotherapy with the prognosis?
No. So the only correlation we had with the ctDNA was with tumor volume. Okay, so patients that had more advanced stage had more ctDNA. We find with the EPOCH regimen, things like stage do not correlate well with the outcome. So that's why we didn't see it, I think, when we looked for outcome. But as I had said, what was very key was if you turned negative by cycle 3, your outcome was very good. If you didn't, that was what really told you that you wouldn't do as well.
Sounds pretty nice, because it looked like a BCR-ABL and CML. For example, 3 months, less than 10% of the BCR-ABL, 3 months, 3 cycle with the DNA. This is incredible.
So we are actually going to be incorporating this in our trials moving forward, and so we are thinking about the various ways that this can be used. I think it's obvious that with large cell, with the AIDS group we treated, we used FDG PET. That worked very, very well. However, something like this could work even better. The other thing is that this could obviate the need to do any more scans, because in every case that relapsed beyond 6 months, the ctDNA turned positive before the scans did.
Very nice work, Wyndham. So are you aware of the Sequenta technology?
That's this.
They are able to do this under the coverage of insurance, right?
Yes.
Okay, thank you.
So the company got purchased by Adaptive, but we did this when they were a separate company.
One cannot say, but now the adaptive technology is better than Sequenta. So
What's that?
the adaptive technology is better than Sequenta. So
no, because they're the same.
no, but they had a different technology.
They did, but
yeah.
Adaptive purchased this. So the clonoSEQ is the Sequenta technology.
Okay.
Yeah, clonoSEQ is the registered trademark of
From
this.
Sequenta? Okay.
Yeah.